Good morning, afternoon, and evening, everyone. My name is Francesca Alvarez, and I'm a policy analyst at the Population Reference Bureau, where I lead our support to the Interagency Gender Working Group, or the IGWG, which is supported by the USAID-funded Propel Health Project. On behalf of the IGWG, we are thrilled that you all could join us for our 2023 annual plenary, Breaking Barriers, Addressing Gender Inequities Facing Global Health Workers. As we get started, we invite you to introduce yourselves in the chat by sharing your name, organization, and where you're joining us from. Please note that we are offering French and Spanish interpretation during this event. So at this time, please click the globe at the bottom of your screen and select the language, either French, Spanish, or English, the language that you would like to hear throughout the event. Next slide. Before we dive into today's event, I do want to share just a few exciting IGWG updates. Our first update is that our first installment in our IGWG Members Take the Mic blog series was published today. This blog, developed in collaboration with the Agency for All project, shares insights from a literature review which aimed to explore myths and misperceptions, social consequences, and cross-cutting factors associated with reproductive agency and infertility in sub-Saharan Africa, as well as identify promising infertility-related social and behavior change and gender transformative programs. This blog offers recommendations for next steps for gender transformative research, programming, advocacy, and policy on infertility. My colleagues should be sharing a link to this blog in the Zoom chat now. I'm also pleased to share that the IGWG team is currently developing a new discussion forum platform where members will be able to connect with each other, pose questions to the community, discuss IGWG-related topics, and receive input and feedback from other IGWG members. We are expecting to launch this platform in the coming months, so please stay tuned for more updates. We are so glad that you're able to join us for today's IGWG annual plenary event. Today, we will examine gender inequities faced by health workers working in the health system. Similar to other workers, healthcare providers also face gender inequities at work. Just like we saw in the Me Too movement, health workers face sexual harassment and violence in the workplace. Societal gender norms can influence which career path health workers pursue, leading to occupational segregation and limited pathways for leadership positions for women. As an employer, the health system often falls short in implementing human resource policies fairly, including how health workers are recruited, contracted, and paid a fair wage. The scope of the problem within the health workforce is quite large, as you'll hear from our panelists shortly. The research from other labor and business sectors tells us that addressing these inequalities could lead to a stronger workforce, a more sustainable health system, and ultimately improve health outcomes. This is an important topic for IGWG because we have observed that despite the scope of the problem, it has received relatively little attention from the global health community so far. So, should this topic be getting more attention from us as researchers, implementers, advocates, and donors? We hope that today's panel discussion and your own insights will help us answer this question and help make some forward progress. The event aims to first learn about the gender inequity barriers health workers are facing in the workplace. Second, understand opportunities for addressing gender barriers to promote a more equitable and inclusive workplace for health workers. Third, explore promising practices and lessons learned from innovative program interventions addressing gender barriers in workplaces throughout the health system. We hope you will leave this event better prepared to examine gender inequity in your own organizations and to promote more equitable and inclusive workplaces, both within and outside the health system. Next slide. We have a rich, action-packed agenda, and we're looking forward to and encourage your active participation. The key takeaways and recommendations emerging from our event will be packaged and shared with IGWG members afterwards. Next slide. We will begin the event with a short interactive activity and will then turn to a panel discussion led by a diverse group of program implementers, health workers, and researchers. During this panel discussion, a graphic recording artist will develop a graphic in real time, incorporating points from this important discussion. Following the panel discussion, participants will join breakout rooms designed to provide you all with an opportunity to share your personal experiences facing and/or working to address gender inequities in the health system in your settings. We'll then reconvene as a large group, and breakout room facilitators will share a few key takeaways from small group discussions. We will end the event with closing remarks and share a link to a post-event evaluation. I have just a few brief housekeeping reminders. First, again, we are offering French and Spanish interpretation during this event, so please click on the globe at the bottom of your screen and select the language, either French, Spanish, or English, that you would like to hear throughout the event. Throughout the plenary session, please mute yourself and turn off your video to minimize background noise and competing screens. You'll have the chance to discuss and share video in breakout rooms. We invite you to use the Zoom chat throughout the event to ask questions or share comments on the discussion. And if you're having any connectivity issues, please send a message in the chat or feel free to personally message me, and we will work to address them. I'll now turn it over to my colleague Jade Lang to lead us through a brief interactive activity. Next slide.
Hi everyone, I'm Jade Lang. It's great to see you all here today. I'm going to launch a quick poll that's going to gauge some of your knowledge and opinions on gender inequity in the health workforce. So if you could go ahead and answer this first question, and it is, according to the World Health Organization, women represent about what percent of the global health workforce, but earn on average blank percent less than men? And your options are 78 and 32, 70 and 28, 67 and 24, or 58 and 19. Looks like we're getting a good amount of answers, about 50 people so far, and it looks like the most popular answer is looking like 70 and 28% so far. We'll give everyone another 30 seconds if you want to get your responses in. Looks like we have about 64% participation right now. Maybe another 15 seconds if you could get your responses in. Okay, I am about to end the poll, so any last minute responses? All right, so here are the results. The actual answer is C, 67%. Women make up about 67% of the global health workforce, but earn on average 24% less than men. And then we are going to go to the next question, which is, addressing gender inequities in the health workforce is key to a more sustainable health system. And this is just an opinion question. So let us know if you strongly agree, neither agree nor disagree, or strongly disagree. Right, we are getting some great responses in. We have about 65% participation right now, so I'll give everyone another 15 seconds to answer this question before we end the poll. All right, let me go ahead and end the poll. And it looks like 92% of you said strongly agree and 8% said agree. So that's great. We're going to get some really good insights during our event today. So I am excited to get going. And right now I'm going to turn it over to Dr. Michelle McIsaac, who is an economist and the lead for gender equality, human rights, and equity at the World Health Organization. And she's going to give a presentation on gender inequities in the health workforce. So I'll turn it over to you.
Thank you, Jade. Thank you, everyone, for having me today. Good morning to some of you. Good evening to the rest of you. Good afternoon to those of you who are in my time zone. Pleasure to be here. Just a few points of clarification I wanted to give just before I start. So one is that I'm indeed an economist, and I lead the Gender Equality, Human Rights, and Equity program within the Health and Care Workforce Department at WHO. We also have a gender lead, a human rights lead, and an equity lead who are organizational wide, and I'm happy to introduce you to those as needed as we go forward. The second point of clarification I wanted to give before I started was that when I talk about this presentation, I'm going to be talking about the health and the care workforce. And this distinction is important for us because it covers not only those who are doing direct health care, but also the care workers who are involved in routine daily tasks of living. So these are in the nursing home environment, long-term care environment, personal care workers, et cetera. So we're really covering the scope of the health and the care workforce. And I'm going to start a timer so I don't go over time. Next slide, please. So just before we started, I wanted to give a little bit of an overview of some context of why this is important. So I think as we highlighted, you are the converted. So you do believe that the health and care sector and gender equality within the health and care sector play a very important role for the workers who are in the sector, but also for health systems performance. But beyond that, it's still really important to think about women and their roles in economy. And what we know is that women still face significant obstacles to participating in the economy as a whole on equal terms with men. So beyond workplace gender equality being fair and the right thing to do, it's also very important from the perspective of women's economic empowerment or women's employment opportunities and women's decision-making power in the economy overall. So it's an important sector, strategically important sector is what we often say. Because it's a large sector, it's a resilient sector, and it's a fast-growing sector for jobs. So what we know is that 1 in 30 jobs across the world is in this sector. So if you're in a room of 30 people, at least one of those is going to be working in the health and social care sector. We also know that on average, globally, 67% of health workers are women. So this is a statistic coming from all of our member states in 2020. In 2013, the number was 70%, but that's changed over time. And 3 percentage points more men have entered this sector over the past decade. So it's becoming a more attractive sector to men over time. And I think this distinction is important, and it doesn't get enough play, if you ask me. Next slide, please. So although we have some global statistics, it's really important to think about the nuance under those statistics. And there's 2 nuances I want to point out. So the one nuance is that although 1 in 30 jobs is in the health and social sector worldwide, these jobs are not equally distributed. So we have some countries where 1 in 10 jobs is in health and care. Those happen to be on average high-income countries. So we have the average for high-income countries is that 1 in every 10 jobs is in a health and care sector. The average for low-income countries for this sector is 1 in 100 jobs. So the role that the sector is playing in economic empowerment, in this story of women's economic empowerment, is quite different across countries and very different across low-income and high-income countries. This slide here is trying to point to the fact that there's really important hidden realities under the wide range of women's participation in the sector. So I think most of you went towards 78% being the global average, when in fact it's 67, more men are joining. But if we look across regions, it's not 67% everywhere. So what we know is that in the African region, in the Eastern Mediterranean region, and in the Southeast Asian region, women are holding closer to half the jobs, whereas in the Americas, the European region, and the South Pacific, or the Western Pacific region, especially in those high-income countries, women are holding more like 3/4 of the job. So we are having a narrative that's sort of being driven a little bit by what's happening in high-income countries, and we really need to redress that. Of course, when we look at countries, and not just regions, we see even wider variation. So there are countries in the world where 10% of health workers are women, and there are countries in the world where 90% of health workers who are paid are women. So looking at the average, I think, tends to have us missing the fact that women are still facing significant obstacles to participating in the economy as a whole on equal terms with men. Next slide, please. The fact that we are in 2023 and we live in a world where 2.4 billion women do not have equal economic opportunity as men in their countries. So according to a World Bank study that just came out in 2023, there are only 14 countries in the entire world, all of them high-income countries, that have laws giving women the same rights as men. So that leaves 176 countries that maintain some form of legal barrier that prevents women's full economic participation. And if legal barriers in terms of access to paid employment aren't enough, there are social norms which tend to allocate unpaid care work to women. We'll spend some time on this in the next slide, and we'll touch to the fact that gender inequality and the types of jobs that women and men hold within the sector are different, as well as looking at working conditions and pay. Next slide. So one core barrier that we see for women entering paid employment, be it in health or any other sector, is the fact that they perform an estimated 4 times more unpaid care work than men do. So this unpaid care work impacts their participation in paid work. And it's actually estimated that 42% of women who are outside the labor force, so they're not in paid employment, are outside of the labor force because they are doing unpaid care work or because they have unpaid care responsibilities that they're attending to. So unpaid care work is the kind of work that tends not to be captured in traditional measures of work. It is indeed work, but it's not measured. It's not work that we measure in our labor force statistics because it is unpaid. So it makes it really invisible in national statistics, and it's being treated kind of as non-work, leaving much of what women are doing to propel our economies as unrecognized. And so there are clear gender inequalities with respect to the gender division of unpaid care work and who bears the cost then of this unpaid care work. Next slide. But even within the world of paid care work, there are gender inequalities with regards to the types of jobs that women and men are doing. So this is what we call occupational segregation by gender. So we have 2 kinds. One is called vertical and one is horizontal. I'll start with horizontal. So horizontal occupational segregation by gender is the tendency for women and men to do different kinds of occupations. So social norms, they tend to ascribe women into occupations of taking care and men into occupations of taking charge. And this, to me, is well represented in the photo I've put up here on the left-hand side of the screen, which caused a social media stir if you've been watching this area in 2019. And this ascribes little girls to become nurses and little boys to become doctors. The second form of occupational segregation is vertical. So this is the fact that men tend to dominate the highest, most prestigious, high status roles within occupations, even those occupations that are traditionally female. And this is represented by the right-hand side of the screen, where we have higher status roles such as the deans of public health and medical schools, the delegations that are sent to the World Health Assembly, and CEOs of health companies being primarily men. Next slide. The next area where we see a measured difference is in working conditions. So what we see across the health and care sector is that women and men are not only segregated into different occupations, but they're also that women are more likely than men to hold roles where the employment is what we call precarious. So what do I mean? I mean that women are more likely to be in part-time work, which tend to have different employment conditions. They tend to also hold jobs that aren't permanent contracts. So they're less likely to have a permanent contract than the male counterpart in this sector. Their jobs are therefore less secure. And we saw, no surprise, that during the COVID-19 economic slowdown, where some jobs were lost in this sector, the majority of those jobs were lost by women. So women had a higher tendency to lose their jobs when the economic slowdown came in this sector than men did. Although overall, the sector was quite resilient during that time, as you can imagine. And then not all women and men, and I think this is an important point to make here, are facing the same kinds of constraints. So we have data that shows that women who are migrant health workers, those who are from other groups experiencing marginalization, tend to fare worse, particularly in terms of working conditions in their workplace. And the other element that we see faring worse both by gender and others is violence. And it's the safety of the sector itself towards its health workers. So where we see high levels of workplace violence across this sector, there's some estimates that suggest that 62% of health workers in their career will have experienced violence in the workplace. Both physical and non-physical forms of violence are common in the sector. The most common forms being verbal abuse and threats, but there's also a high proportion, 12%, that responded sexual harassment as a form of violence that they've faced. So there's a lot of research that really still needs to be done in this particular area of gender-based violence in the health and care workplaces, or gender-based violence against health and care workers themselves in the broader sense. But on the right side of the screen, you can see that violence that is measured, so that we actually capture, which is underrepresented, is really just the tip of an iceberg, a tip of a gender inequality iceberg, if you may. And underneath, there's gender equality with respect to data, protective measures, precarious work, as we just mentioned, low and unequal pay, as we're about to go into, lack of recognition and opportunity. And these are further underpinned by gender biases and gender power relations. So there's really a gender power dynamic story happening once we look underneath what's happening to the violence against women in the health and care sector. We could spend an entire session on this, but we must go forth. Next slide. So finally, we can see that a lot of the gender inequality in its starkest form, I think. I mean, I'm an economist, but when you look at pay. So with pay, we can see that overall the pay in the sector is lower than pay in non-health sectors. So in other sectors that aren't the health sector. If you're even looking at similar kinds of jobs, so a technical role in health and comparing a technical role in non-health, you'll find that the role in health tends to be paid less. We see this pay penalty as a common factor in feminized sectors in general. So not just the health and care sector, which has a high proportion of women, but in other sectors that are feminized tend to be paid less. We tend to value the work that women do lower than the work that men do. And this is also within the sector. When we look at individuals with the same kinds of jobs, so they're in a similar occupation type, so they're both professionals, similar education, similar experience, similar what we would call labor market attributes, we still find that women's contributions to health and care are valued less than men's. And this is that they make, on average, 24% less than men. And that's trying to control everything we can about who they are. They're still earning 24% less than men in the health and care sector. Next slide. So if you want more information on that, certainly go to our report that we launched last year with the ILO. I'm sure the organizers will send the link. So what can we do? I mean, I think one of the parts of this solution is to address the underinvestment in caring sectors, such as the health and care sector. Another is to look at ways to address the social norms that result in high levels of occupational segregation by gender. Trust me, men are really good at providing care and women are really good at making decisions and taking charge. A lot can be done to standardize working conditions between men and women. and address the gender inequalities that are underpinning gender-based violence in the workplace. Tackling occupational segregation and improving working conditions will go a long way to helping to close the gender pay gap, but we also need legislation to enact equal pay for work of equal value. So that is that if you're performing the same job that has equal value as another person, you should be paid the same amount, regardless of your gender. Then we need certainly more and better data. So we need to understand the nuance behind the statistics, how the data is interacting with other factors at play. We need gender analyses to understand some of these dynamics, and we certainly need to do better in terms of monitoring and evaluation. So there's so much that can be done, and I'm really looking forward now to hearing from this panel of implementers, of advocates, of health workers on what they see as the major steps that are needed for a more gender equitable health and care workforce.
Thank you, Michelle, for that fascinating and informative presentation. I know I definitely learned a lot about the inequities that health workers are facing. So we are just about ready to begin our panel discussion. And during this portion of the event, we invite you to please put questions for panelists in the chat, as there will be a Q&A session following the panel discussion. I'd also now like to introduce our panel moderator, Dr. Shabnam Sarfraz. Next slide. Dr. Shabnam Sarfraz is the Deputy Executive Director at Women in Global Health and also the co-founder of WGH Pakistan. Prior to this, Shabnam worked for the Federal Planning Commission for the Government of Pakistan, where she led the National Social Sector Portfolio and was responsible for the COVID-19 response planning and resource mobilization. Additionally, she served as the national focal point for coordination with ministers and senior bureaucrats to facilitate investments in social development with a cross-cutting focus on addressing gender inequality. Shabnam has also previously served as the Senior Technical Advisor at Marie Stopes International, UK, and is also a medical doctor with an MBA and Leadership Fellowship from Harvard University. I'll turn it over to Shabnam now.
Thank you so much, Francisca. Greetings to all, whether it's morning, afternoon, or evening in your part of the world. We gather from various corners of the globe for significant and enlightening panel discussion. Our focus today is on convergence of gender transformative programs, workplace inequalities, and the advancement of health and gender parity within the health system and amongst the health workers. It's a genuine honor for me to take on the role of moderator for this important dialogue today. While working as the National Health and Gender Lead for the Government of Pakistan and leading the COVID-19 response, coming from a country which ranks the second lowest in the Gender Parity Index, I experienced firsthand how inequities within the work environment, especially those affecting health workers, have far-reaching consequences that extend much beyond the organizational boundaries. It is heartening to see the increasing recognition and commitment to addressing these issues through gender transformative approaches. Without further ado, let us embark on this journey of exploration and enlightenment as I move on to introduce our esteemed panelists. Allow me to introduce Dr. Amina. Dr. Amina is a distinguished individual with impactful contributions in public health. Dr. Amna Aminu, the Nigeria Country Director at Pathfinder International, has a background as a physician and public health specialist. She has dedicated nearly 2 decades to enhancing health outcomes in Nigeria, particularly for women and children. Her leadership at Pathfinder International involves building local partnerships and resilient pathways to sexual and reproductive health and rights. Dr. Amna's experience with organizations like Abbott Associates and IPAS, along with her work in hospital settings, makes her a valuable voice in our discussion on health systems and gender equity today. My next panelist today is Sybil Wongal Fekadu, and we are delighted to be joined by her, a distinguished gender expert with a decade of experience across the health sector and beyond. Her roles span gender advisor, specialist, consultant, and more reflecting her expertise in gender mainstreaming, diversity inclusion, and organization development. Sibel holds a master's degree in gender studies and a bachelor's degree in social sciences with a minor in management and public administration from Addis Ababa University. Her insights greatly enhance our discussion today. Dr. Michelle McIsaac, we just heard her as eloquently presented earlier, is indeed an impressive addition to our panel. A distinguished economist and health workforce specialist, Michelle is a steadfast advocate for gender equality. Her tenure at the World Health Organization since 2016 has seen her lead the health workforce department's charge towards gender equality, human rights, and equity. Michelle's work encompasses critical areas including the care economy, women's economic empowerment, health workforce policies, and equitable access to healthcare professionals. She has demonstrated her policy acumen through contributions on subjects such as health workforce retention, gender equality, care work valuation, workplace violence, and wage disparities. Michelle McIsaac's dedication and insightful contributions are expected to add immense value to our discourse today. Finally, let me introduce Catherine Chacha. Catherine Chacha, whose accomplishments are truly commendable. Armed with a Bachelor's of Sciences in Nursing, Catherine is actively pursuing her master's in field epidemiology and laboratory training at Moy University. Over the span of more than a decade, she has accumulated invaluable experiences across various levels and roles in sexual and reproductive health and gender-based violence. Catherine's journey has led her to serve as a resident within the Ministry of Health in Kenya for the past 3 years, a role that showcases her dedication to improving health systems. Currently, she's based in Migori County government, and she continues to demonstrate her leadership and advocacy skills with a special emphasis on women's health and the battle against gender-based violence in Kenya. Catherine Chacha's presence is truly an asset to our discussion today. Let's kick off our session by welcoming our esteemed first panelist, Catherine, whose expertise and insights are very much likely to set the tone for our discussion today. So, Catherine, my first question is to you. You are currently working as a health worker. Can you share any examples of gender discrimination and bias you have faced or observed as a health worker? Over to you, Catherine. Catherine, can we have you in here now? Okay, if there are any connectivity issues, I'll just move on and we can bring in Catherine. Are you there, Catherine?
Yes, sorry, there was power blackout. I've managed to connect.
That's okay. That's okay. So my question to you, Catherine, is that as you're working as a health worker, if you could share any examples of gender discrimination or bias that you may have faced or observed as a health worker. Over to you.
Thank you so much, Shabnam. As a healthcare worker, this question, when I hear it, I remember quickly the moment I started working, and my second employment as a young nurse was in a private health facility where the pay was below $200, and we were working for very many working hours. Like it was a 12-hour shift, and sometimes it would go overboard. The sad point of it, I took it to be a very normal encounter as a young nurse being employed in a health facility. But later I realized when I had worked for 3 months and did not get pay, and the argument was there was no money to pay us. Most of us were female healthcare workers and were leaving the facility without getting our pay and being underpaid. So 2 key things that healthcare workers undergo is, one, there's low pay, and at times there's no pay, which is very demoralizing, being female, and then most of us having families. And then there's an issue of sexual exploitation, abuse, and harassment. It is highly unspoken of. But when you encounter your fellow colleagues they'll always take it to be normal. I was harassed at the workplace. It can be from your fellow people you're working with, or it can be from outside clients or patients coming into the health facility. But this is very much unspoken and nobody wants to speak about it loudly. Those are the three key things that I can pick in terms of discrimination and abuse, violence at the workplace.
Thank you, Catherine, for sharing your insightful and personal perspective on this topic that many find difficult to converse on. I'm tempted to ask you on a follow-on question. In your opinion, Catherine, of the many gender discrimination issues faced by health workers, which issues are the most important to address in your setting, and why do you think so?
I'll pick on sexual exploitation, abuse, and harassment, because if you also look at the Health 2 report that was shared by Women in Global Health, it came out clearly because it gave opportunity for female healthcare workers to speak anonymously on what they're undergoing. And interesting, even from Kenya, most of the healthcare workers who spoke up, including community health volunteers who are the level 1 of care, they might not be healthcare workers. It was being sexually harassed, abused at the workplace, and they have no one to share it with because they feel when I say it aloud and it is my boss, what comes in? How will people take it? What kind of punishment, or how will I go back to the workplace where there are no clear rules on what will protect me, or who will I report to? So among the three, I'll really pick on having a clear discussion and strengthening providers to understand that sexual exploitation, abuse at the workplace is there, and they are not to be blamed, and they have a voice to speak out.
Thank you, Catherine, for your very powerful insights, which are bound to enrich our follow-on conversation. I would now turn to Amina and invite you, Amina, to share a few details about your progress and on the programs which for addressing gender inequities facing the global health workers. What successes did your programs achieve, and how did the healthcare providers respond to the programs or the tools? Over to you, Amna.
Thank you, Shabnam. I hope you can hear me well.
We certainly can.
Great. So today I'll be talking about my experience with a project that I worked with before I joined Pathfinder International, called the Sustaining Health Outcomes Through the Private Sector, SHOPS Plus in Nigeria. And this was USAID's flagship multi-year approach implemented by APT Associates to improve contraceptive use among couples of reproductive age, including long-acting and reversible contraception in 4 Nigerian states. And this was by building capacity of public and private providers through in-service training and improving the quality of family planning, counseling, and service delivery. So at inception, the project conducted a gender assessment to identify key gender-based constraints and opportunities to provide recommendations and improve contributions to have a gender-responsive family planning service delivery approach. And as part of the findings, we found out that health workers, trainers, coaches, and actually supervisors received minimal gender training and were not deliberate about identifying and addressing gender-related workplace issues that were faced by health providers. So the project that was SHOPS Plus, we applied a gender lens, both to the client issues and also to the human resource management of health providers because of its impact on even the outcomes of care. So what we did, therefore, was to strengthen the coaching and supportive supervision system by introducing what we called a gender transformative supportive supervision, or GTSS intervention in the states that we worked in. And in general, we all know that supportive supervision is supposed to be based on establishment of mutual trust and consultative communication between supervisors or coaches and also the providers that are working in the health facilities. But the traditional health worker supervision system that we are used to actually does not consider certain critical elements like gender-related workforce issues that supervisors themselves have not really experienced. And let's know that most of the supervisors are usually males as well, so they wouldn't have experienced what other females in the health facilities have experienced. And we believe that these supervision visits actually present an opportunity to explore and address the influence of gender dynamics on the work environment, and then consider ways in which these gender norms and even the power dynamics could affect the interactions between supervisors and health providers. So there were issues related to balance of work and home responsibilities between coaches, supervisors, and providers, assumptions about what the natural or caring leadership positions are, the career trajectory. For instance, women are usually those that occupy the nursing profession, even in Nigeria, and also the community health extension worker positions, which are usually the cadre that are mostly available in primary healthcare facilities. Also, one important issue is safety issues in the workplace, among others, because most of the time you would see that health workers are not able to stay long, maybe throughout the day, because we don't have, a safe environment for them, especially for women. So what we did was we had the coaches and supervisors receive a gender transformative supportive supervision training. And this helped them to identify ways in which gender can actually influence health worker performance and retention, and even the relationships between supervisors and providers. It also helped them to reflect a positive attitude towards building gender transformative workplace that is free of discrimination, and demonstrate coaching skills that are gender aware and free of bias. So through this methodology of gender transformative supportive supervision, we're able to support these coaches and supervisors to examine preconceptions that they had, their internal biases, and also assess each of the providers' performance objectively when they go for these supervision visits. So they also had to help each provider, reach his or her peak performance and career goals based on the individual, because they are able to proactively identify any gender-related barriers or biases that negatively impact the provider's performance. So at every supervision visit, these providers are asked questions on workplace gender discrimination that could be in the form of policies, such as those that are related to sick leave, maternity or paternity leave, equal treatment between males and females, breastfeeding policies, or even sexual harassment, as we heard earlier. And there are also career progress, safety issues, as I talked about, and for their travels between their their facilities and homes. And the appropriate authorities were usually informed, for necessary action if we found any issue. So in general, the Shops Plus project did more than just train in purely clinical skills. The training approach and post-training activities incorporated components of gender and provider bias, and this helped providers to improve their productivity, specifically in the way they deliver family planning and increase women's access, at the facility level. Thank you, Dr.
Thank you, Amna. Thank you so much for sharing these findings from your programs and how coaching and supportive supervision played such a critical role and impacted the gender and power dynamics at the workplace, as you shared. You touched on the safety issue, which is critical to retaining a fast exiting female health workforce, particularly in the low middle income countries. Next up, we have Sybil Wongel, who I would want to invite now to share her thoughts on the same topic. Sybil, would you want to share how your programs are addressing gender inequities facing the global health workers, and what successes in your programs would you like to share, which could set up as a learning? And how did healthcare providers respond to the programs and tools that you may have introduced? Over to you, Sybil.
Thank you, Shabnam. I am presenting on 2 consecutive USAID-funded projects, Human Resource for Health Program and the Current Health Workforce Improvement Program, HWIP. Both projects had the overall goal of improving the human resource for health in Ethiopia. This project has been implemented for more than 9 years, and it is being carried out by the PIGO-led coalition. The project aim is to improve gender parity in health workforce through 2 key strategies. One, by improving graduation rate and academic performance of female students in health professionals education, so that more competent women would be able to graduate and enter the health workforce. and to ease by advancing women's leadership in the health sector. Human Resource for Health project supported initiatives of the Ethiopian government to improve the retention of female students enrolled in health programs at 52 public universities and regional health science colleges to establish and strengthen gender offices and gender clubs for their health college and to conduct gender transformative activities. Some of the examples of which you can see listed on the slide. We provide both technical assistance and financial support for gender offices. For example, the project provided training of trainers, courses on life skills, counseling skills, and gender responsive pedagogy for gender focal persons, counselors, and faculty at supported higher education institutions. The project also supported the adoption and implementation of the Ministry of Education's anti-sexual harassment policy and the development of case reporting and monitoring tools at higher education institutions. Involving female students in gender clubs and student council in decision-making roles and have an avenue for sharing their voices. Finally, the project also helped to launch a female academic forum, which serves as a network for female academics and advancement of female leaders and involving in research. In regards to women's leadership in the health system, this work has been guided by the training package on gender transformative leadership. The HW project has trained human resource managers and health leaders in components of gender transformative leadership curriculum as a part of larger training on learning, management, and governance. It includes training on issues such as gender-related biases, sexual harassment, communication, networking, and mentorship. The project conducted a workshop on workplace safety and GBV for 50 human resource experts and managers to address women's safety and health with an emphasis on gender-based violence in the workplace. The project also advocates to improve the working environment for female health workforces in availing daycare centers in their working areas and the flexible time arrangements for lactating female health workers. Through our program intervention, the female graduation rates at higher education institution is increasing incrementally. For example, in year 2021 to 2022, graduation rate of female students increased from 80% to 85%. Informal evidence suggests that female students felt more confident and comfortable speaking up for themselves in the classroom and community after life skill training. Some even assumed leadership roles on student councils and committees, advocated for themselves and other women in campus, and worked to challenge gender stereotypes. Direct financial support and tutorial classes also helped improve the attendance, concentration, participation, and test scores, while rewards for female students who excelled in school was an important motivator. We have also seen some improvements in women's leadership in the health workforce. In year 2020, women made up 30% leadership position in different levels of health organization. And in year 2022, that had increased to 39%. We have also heard feedback that leaders participating in the gender transformative leadership training have started being more interested in finding ways to promote women into leadership position and support them. Yeah, these are some of our successes in response.
Thank you, Sabir. Your sharing of the HRH project insights and the multi-strategy approach that you adopted in Ethiopia provides learning for many in the sessions today. I'm personally fascinated with the jump in female leadership from 30 to 39%, which is truly commendable. I would want to come back to you, Amina, and invite you to share any challenges from your program interventions that you shared earlier that you would want to share with the audience and would want to reflect on. Amina, over to you.
Thank you very much, Shabnam. Yes, so as a project that actually introduced gender transformative supportive supervision, which was not really what was being implemented in these states. And, this intervention actually sought to challenge gender norms, that is the traditional gender norms. We encountered some challenges during implementation. One example is that, even from the presentation that we had today, we all know that gender norms are quite deep-rooted and affects attitudes of everyone, including the coaches, the supervisors, and even the healthcare workers that we worked with during implementation. So during the gender transformative supportive supervision training sessions, we actually recognized that many of the trainers, the supervisors, the coaches had at some point contributed one way or the other to the gender-related barriers that existed at the workplace. And we didn't have policies readily available that addressed gender-related workplace issues. For instance, as I talked about security earlier, which affected productivity of especially female healthcare workers, as they could only work during the day because their safety was not guaranteed at night. And at the time of project implementation, reporting of GBV cases, that is gender-based violence, was also very poor, especially among the health workers that we are talking about here. And our governments, especially at the subnational level, did not have clear gender-based violence response policies and guidelines. So some of the health workers did not have trust in the system. And in some of the cases, the culture of silence, stigma, and discrimination made women health workers, the female health workers, cover up any gender-based violence cases that had, and they could not report to the authorities. So as part of our implementation, we had to identify and work with some legal entities at the subnational level and the ministries of women affairs, judicial systems, civil society organizations to even contribute towards reviewing or updating gender-based violence response guidelines, and advocated to decision makers to really do some upgrades at the facility level. And some of them got generators, for instance, as alternate sources of power supply, so that they could be able to work at night, and others had fences raised up so that it could help with the security situation. So these are some of the challenges I could share. Thank you.
Thanks, Amna. Your mention of engaging respective legal authorities highlights, and the other stakeholders highlights the important role that each one of them plays if we have to see a change in this context. Sybil, I would like to turn to you. Would you like to share any challenges from your project, the Strengthening Human Resource for Health and Health Workforce Improvement project that you shared on? So any challenges that you would want to reflect on?
Yes, there are some challenges, but I try to explain. Splitting first, let me try to explain the higher education institutions challenge. That one is absence of formal structure for gender offices, that most of the gender focal persons positions were not formally integrated in organograms. Two, lack of budget, leadership support to the office. And third one is higher turnover of trained gender officers in higher education institutions. And fourth, majority of the gender officers have poor documentation practices. Regarding the health organization challenge, one, most health work organizations do not incorporate gender sensitive environment arrangements such as daycare, flexible time arrangement, etc. And two is not conducting a continuous gender sensitization training for healthcare providers, administration staff, and leadership. And the third one is not having gender sensitive staffing. And for fourth, not understanding of gender roles, norms, stereotype, etc., and not being gender responsive. The other challenges regarding data, even though this project prioritized high quality data to improve the health workforce and sex disaggregation improved vastly, there are still many data missing that could help to better understand the barriers women face as students and professionals and the impact of various programs and policies for gender equality. And the other thing is about scale. In attempt to scale up in the relatively short period of time, we think that some of the innovations have been scaled up without measuring impacts, and often without adequate budget to implement intervention with high quality and fidelity. A comprehensive gender in human resource for health program requires sustained investment and study. Yeah.
Thank you, Sibel. Your listing of these challenges is, I'm sure, a great learning for all of us. After my next question to you is an important one, as I'm sure the audience are very keen to learn your perspectives on the promising practices that program implementers and health system managers should consider to promote a gender transformative and equitable health workforce. Amna, over to you.
Thank you, Shabnam. So from my experience implementing gender transformative supportive supervision under the Soft Plus project, it is clear that there's need to conduct regular gender-related trainings for health workers, for supervisors, managers, staff of all organizations, and even the ministries and agencies that are overseeing the health sector. This will really expose them to gender-related issues that affect the health workforce. It will also help them to recognize their own biases and support them to make the necessary changes to support a more equitable health workforce. I think another promising practice is for implementers to really be deliberate about integrating gender into all program areas. I think in every organization, having a dedicated global or gender focal person that is well-trained to integrate gender across program interventions and even within the organization is a good practice. For my organization, Pathfinder International, we currently have adopted this approach, and we see the value in taking deliberate steps to embed gender within all program areas, including the organizational and administrative level, so within the governance structure, within the structure of the organization. And then lastly, I think health interventions should also consider embedding gender transformative supportive supervision into all supervisory systems, and it has been tested and proven to be an effective strategy in promoting gender transformating health workforce. Thank you, Shabnam.
Thanks, Amna. Integrating gender across all programs is certainly a very valuable practice. Sibel would love to hear from you on the same and would like to invite you to add on to what Amna shared and what promising practices would you like to recommend to program implementers and health system managers to promote gender transformative and equitable health workforce? Over to you, Sibel.
Thank you, Shabru. Advocate for sex disaggregated data and information as to support evidence-based intervention and increase a response to gender issues. Female Academic Forum might have support key gender office activities as well as Female Students Club in advocating for gender parity and tackling gender-based violence at higher education institutions of health science college. Life skill training for newly joined students prevents potential gender-based violence and improved health students' academic performance. Similarly, some leaders' commitment to implement their recruitment policy to ensure gender balance might have a potential to narrow gender disparity in the future. Our project providing gender transformative leadership training to health system managers that can help promote gender equity and empower women in leadership positions. That such training improved gender-sensitive planning and decision-making in the health sector, supports the development and implementation of gender-sensitive policies and guidelines, can help promote gender equity and address gender-based discrimination in health workforce that improve retention of female health workers. Addressing gender-based violence in workplace is crucial for creating a safe, supportive work environment for female health workers, and conducting a training on it for healthcare providers improve job satisfaction and retention of female health workers.
Thank you so much. Thank you. Thank you so much. And I think from my experience as well, the political leadership I would say, the bureaucratic abilities and the technocratic capacities within the health systems are truly invaluable for taking this agenda forward. With this, I'll pass the virtual microphone to Catherine to continue our engaging conversation. Catherine, what recommendations do you have for other health workers facing gender discrimination and violence in making the case for change?
One, I'll advocate for healthcare workers to join trade unions because these are very key. Joining a union is it's very key for them to have a voice, and this will be their voice. So I really advocate for healthcare workers to think about union at different levels, even if it's cadre-based. There are different countries to have unions in place, and then we need to strengthen the unions to have a collective bargain in this conversation. This should be in line with the global conversations on which are the best practices to protect the workers. And then employees should promote networks among women at all levels and to encourage reporting. Because if you have clear networks and clear reporting structures, all healthcare workers will have a voice to speak out. Because the issue is, when I speak out, whom do I tell if I'm undergoing violence or I'm in a situation where I need somebody to listen to? So I really advocate for healthcare workers to use their voice well, because we've noticed once you speak out, somebody listens. And then if you can't, there's a trade union that is clearly there to listen to you, and that can be echoed at different areas and regions.
Thank you so much, Catherine. And I like when you said the voice. We must never underestimate the voice one has. In Pakistan, we saw the lady health workers as they stood up for their rights, and they compelled the government to regularize them as they became regular government employees. And now their salaries are coming from the government funds, and they are being treated as other health workers. But they themselves were the ones who were at the forefront of this struggle. So thank you so much, Catherine, for your thoughtful remarks on gender discrimination, violence. Your expertise in this area is truly invaluable. I'm excited to hand over the floor to Michelle. Michelle, what policy changes, investments, and resources are needed, in your opinion, to address gender inequities in the health workforce? Over to you, Michelle.
Thanks, Shabnam. I think that the main thing is to say that these kinds of policy changes require a lot of hands. So I think it's really important that we think about this, that these kinds of policies we're discussing here, they really require multi-sectoral partnership. It requires coordination, it requires resources and financing. So I think, of course, the Ministry of Health certainly has a role as regulators. In many countries, it's large employers of health workers, and you hear just what was discussed there in that sort of context, but also labor and collective bargaining, as was just mentioned by Catherine, plays a really important role in terms of getting better working conditions for health workers, better contracts, and addressing some of the issues that we see in that space of labor. Standardizing working conditions, obviously. Ministries of gender have a really important role to play, I think, certainly in terms of tackling gender norms. Ministries of finance, I think there needs to be a conversation certainly between gender and finance and health in terms of the value we place on care, so how well we're funding and resourcing this core sector. Education, legislators, laying legal foundations, access to employment. I think all of this is really, really complex. And I think what we're trying to do at WHO in this space is we've enacted a mechanism called the Working for Health platform, which is kind of a platform and an implementation mechanism that's meant to support multi-sectoral collaboration to address these key issues in health. And I think this is a really important space for our discussions around gender, because it brings more than one decision maker to the table. Just to say that we have over 100 countries who co-sponsored the resolution and the action plan on this. So there's a lot of momentum behind that. And I think these kinds of mechanisms and bringing actors together, not just, of course, government actors, but everyone together is core.
Thank you so much, Michelle, for these valuable insights, which are instrumental in our exploration. Coordination, multi-sectoral approach, financing, collective bargaining, and advocacy movements, they all come in and then again with WHO providing valuable platforms and similar platforms as the one that we are over here, we must not underestimate the power that these hold and for us to take this forward. So as we approach the conclusion of our session, I kindly invite each panelist to share a concise 1-minute response to our final question, encapsulating the key takeaways from our discussion. Your insights will provide a fitting wrap-up to our conversation. So Amina, I'll first turn to you. What's one action donors can take to address gender inequities in the workforce?
Thank you, Shabnam. So I think donors have a very important role to play in making a difference in the situation of health workers. And because we know program implementers and even in some cases, government stakeholders align with donor priorities, it will help if donors could earmark resources in every funding cycle for gender transformative work. Implementers often have great ideas, but without adequate funding, the initiatives cannot be rolled out. Donors could also consider funding specific gender transformative challenge initiatives as part of a comprehensive and integrated health agenda to allow implementers to be innovative and learn lessons as they progress. Thank you, Shabnam.
Thanks, Amna. Thank you. Catherine, what's one action researchers can take to address gender inequities in the workforce?
One thing is they need to deepen understanding and have evidence base for policy with more research and data. And this can be done by implementing research so as to explore why policies are not working and identify the gaps for further action. So it's going around and seeing there are policies available, but why are they not working and what can be done to the gaps available and strengthen the policies that protect women. Thank you.
Thanks, Catherine. Michelle, so what's one action you think that WHO is taking which is most vital towards addressing gender inequities in the health workforce?
Oh, thanks for the question. I think for me, it's really in terms of mainstreaming. So we talked a little bit about what's happening. I think that leaving, putting gender equality issues aside and not mainstreaming them through all of the policies and programs that we're doing is not helpful. So I think it's not that we want to make a singular commitment to gender equality over here and monitor it over here. We really want this mainstream through all of the policies and programs that we're doing. This is what we're trying to do through the Working for Health Action Plan. So when we're providing country technical support, that gender equality lens is part of that and not an optional add-on. So it's not contingent upon necessarily, a request for specific help on a gender topic, but it's something that we need to be doing in all of the policies and all of the planning we're doing and all of the data work we're doing across the board. And I think putting it in everything, I think that's what one of the colleagues had said, is absolutely key. And it's really the initiative we're taking now, running towards 2023 or 2030 with Working for Health.
Thanks, Michelle. Taking this holistic approach is certainly very critical. Sibel, I'll turn to you. So what's one action program implementers can take to address gender inequities in the health workforce? Sibel, are you with us? Okay, so if anyone, I think
Sorry, I just...
Oh, okay, you're there. All right. Okay.
Okay.
So would you like to share one action program implementers can take to address gender inequities in the health workforce?
Okay, I would like to say for program implementers, specifically for human resource managers, that developing and implementing gender-sensitive recruitment and promotion practices to ensure equal opportunity for all genders, and an affirmative action or quota system must be applied to encourage women. The other one is providing training and development opportunities to support the career progression of women and other underrepresented groups in the health workforce, and establishing a workplace culture that values diversity and inclusion and actively promotes gender equality. These are the points that I would like to share. Thank you.
Thank you so much. Thank you. So as we conclude our plenary discussion with this, I'd like to extend sincere gratitude to our panelists for their valuable insights. Now we invite you, the audience, to actively engage in our Q&A segment. Unfortunately, we are running short of time, but I would highly encourage you to type your questions into the chat. And if you prefer, use the raise hand feature, as we'll be taking 2 questions in person. And your participation is what drives the heart of our conversation. So let's dive into this interactive brief session. But as I said, please feel free to type your questions into the chat, and the panelists will be happy to respond to them. So anyone who would want to come in, and I don't see any show of hands as for now. So any questions from the audience who would want to put across any question here? So there has been an active conversation in the chat box. So perhaps as we are getting questions in the chat box, I would encourage you to continue to do so for the remaining part of the session as well. And with this, I think as we do not have any show of hands so far, so I would like to conclude the panel discussion. Please feel free to continue to interact in the chat box. My final remarks would be that together, let's envision a future where gender transformative programs not only address workplace inequities for the health workers, but also pave the way for a healthier, more equitable world for all. I would hand it back to Francisca to take it forward from here. Thank you all. It was such a pleasure being with you today.
Thank you, Shabnam, and thank you to all of our panelists for leading such a fantastic discussion. I know that I thoroughly enjoyed the discussion and learned so much from you all, and I'm really excited to head into the breakout rooms for small group discussions. I think everyone is back in the main session, so I think we can transition into report back.
All right.
Thanks, Shabnam. Thank you, everyone, for all your contributions during the breakout rooms. I was hopping around between the rooms and really listening in on some insightful discussions, and it seemed like everyone has a lot of energy for these topics and a lot to offer. So thank you for sharing your experiences with us all. So I'm now going to ask breakout room facilitators to share just a few key takeaways from your groups. Would recommend keeping your takeaways at 2 or max of 3, just because we are running short on time. So we'll start with group 1, which was Catherine's group. Catherine, can you share some highlights from your discussion? Catherine, are you still with us? I see you on the line. She might be having technical difficulties. Well, would someone else from Catherine's group be willing to share some highlights from your discussion? Any volunteers from Catherine's group who would be willing to share just 2 to 3 key takeaways from your discussion? I can. Oh, is she back?
JD, sorry, I was trying to unmute. So the key takeaway was it came out clearly the importance of multisectoral approach in multisectoral approach, and then data came out as part of the conversation, because for all this to be achieved, we need data, and there's an issue with data gaps. Then there's need to raise awareness about gender inequality issues, because the healthcare workers themselves, some of them don't know what they're undergoing, and there's an importance of them to know this is wrong, and there's a system in place that they can report. Then it's important to have policies around sexual harassment at the workplace, as well as educating them on these policies, because some of them might be undergoing violence, but they don't know their policies that are protecting them. And then we talked about, in organizations, you should have a gender-focused person on board as beginning of a program design to inform programming. And we got examples from different organizations. One talked about they need to strengthen support supervision, the support supervision approach, and then involve the private health sector in this discussion, because if healthcare workers are also working in private health sector and they're also starting their own private businesses, they need to have them. And then for the counties or countries that have the subnational levels, like we have counties in Kenya, there is need to have mainstreaming of gender with the subnational levels and integrating with the national level for all of them to speak one language, and then supporting health workers to do advocacy through unions, and then have dialogue platform. So the unions should have dialogue platforms with the employer. This can be like a work council, because when you have dialogue platform with the employers, it becomes easy for this intervention to come in, or the union to raise the issues that are available. You can go into the next question. I think the key inputs that we had as the last one, and then the next one, the next slide. Then this. So lastly, it's important. I think it's the previous one. Sorry, the previous. Yeah, it's important to pay community level workers, because the lack of pay and conflicting responsibilities are barriers for women wanting to be in the health workforce. So there's recognition of level 1 of care, which has majorly community health workers. So it's important to look at them and also have their pay, because most of them have no pay or low pay working in different countries. Thank you.
Thank you, Catherine. It sounds like your group shared a lot of helpful recommendations. We'll move on to group 2. Amina, can you please share some highlights from your group's discussion?
Thank you, Francesca. We had a very interesting and robust group discussion in our group. And I'll just share a few highlights, not really specifically across the questions, but just in general. And I think one of them was, at least 2 people talked about, how they really takeaways that stood out included, the role of unions. Catherine shared about how, forming unions and joining movements of health workers could also help in, representing concerns around, gender-based violence, or this role of women in decision-making in labor rights. And also it was a really a high movement and a discussion point for the team in terms of a really good lesson that was learned from here. So learning, joining these movements, joining unions of health workers. Again, we had some lessons that were learned, because, the question came up around how can points be made more gender sensitive. I think we have it here. And we got a very interesting lesson, or a very interesting suggestion, bringing male models. So we always talk about male models that stand up for the rights of women, who one of our group members rightly called male feminists. And, they could help in addressing any gender-related issues, and they could serve as role models for young boys. I think maybe a few more takeaways was also, how do we address resistance to challenges? Because we're working with, gender issues and trying to challenge gender norms, we know that there's a lot of resistance. And how have we, maybe documented these power dynamics, these challenges, and how have we, monitored this resistance? So these are some of the areas that we think we could do more about. And one last one that also came out that really resonated for me and was shared in the group is also cultivating and celebrating leaders that are setting the right tone and putting forward policies that are relevant to the work that we're promoting or to the gender-related barriers. So when we have positive examples that we really need to highlight them and point them out. And one discussion is also, in any of the meetings, global meetings that are coming up, including the UN General Assembly, discussions on universal health coverage, we need to be there to also make sure that discussions around gender equity in the health workforce is also part of the discussions. Thank you very much.
Thank you, Amina. Moving on to group 3, Shabnam, can you share just a few highlights from your discussion?
Absolutely. So when asked about the key takeaway, I think one of the prominent one was a holistic approach, engaging stakeholders across multiple sectors is needed for gender mainstreaming across all policies and programs. And then we had some good feedback on the lessons learned that they would wanted to share. So evidence generation into gender conducive work environments, advocacy using evidence for a collective voice and influencing policymakers, gender disaggregated human resource for health profiles, and participating at high-level policy forums and using the power of your voice. Around the challenges, gaps, and opportunities, there was quite a lot of feedback. So very few women in the decision-making role, sexual harassment of health workers on the rise, female health workers double burdened with the work-life imbalance, challenges of having male-dominant policy groups insensitive to issues of female health workforce, need to keep the topic front of mind throughout decision-making, not just at certain moments, lack of political commitment or recognition of this as an issue, inflexible work policies for working mothers, gender pay gap in the health sector, and I think in terms of opportunities, linking the workforce retention to the national goal of universal health coverage and gender evidence to show link between pandemic response and workforce retention and motivation. We asked for any innovations that could help strengthen gender equity in workforce. By this time, I think I was the only one in the room and everybody had joined back. So I shared 2 examples from Pakistan as we conducted a survey across 42 ministries in Pakistan to assess gender conducive work environments and presented it at the highest policy forum. The evidence compelled the policymakers to declare 2022 as the year for respecting female employees. So never underestimate the power of evidence in strengthening your advocacy. Based on that, there was appointing of gender focal persons in each and every public sector office within the government of Pakistan to steer the gender mainstreaming initiative. So I'll park here and would love to hear from the other group.
Thank you so much, Shabnam. So our final group, led by Elizabeth. Elizabeth, if you can share just a few, we are running short on time, so if I can ask you to keep it to really 1 or 2 highlights that have not been mentioned so far. Thank you.
Absolutely, thank you. And we had many of the same discussion points as the other group, so I will be quite quick. One of the ideas that kept coming up in different parts of our discussion was the idea that investing in equality within the health workforce and investing in the safety and security of health workers and the well-being of these important people in the healthcare system also is likely to translate into higher quality of care. And in fact, likely more gender sensitive care as healthcare workers, supervisors are trained in gender norms and roles. That's likely to also translate into how they interact with patients in the community. So I'll stop there. Many of the same points as other groups.
Great, thank you so much, Elizabeth, and thank you to our facilitators and the participants of the breakout rooms. Thank you for sharing your personal experiences with these topics, and it's been really great to hear some of your recommendations. So before I turn it over to Deanna for closing remarks, I would like to just make one request with the request to you all. Please take a few minutes to fill out a brief post-event evaluation survey. My colleague Devin should be sharing links to the survey in English, French, and Spanish in the chat now. Your feedback really will be extraordinarily valuable to the IGWG team as we plan for future events. So we'll ask that you please take just a few moments to fill out those form or that evaluation form. And I would like to just say a few words of thanks. So thank you to our panel moderator, Dr. Sarfraz, and to all the panelists for their immense contributions to this fantastic, important discussion. I'd also like to thank our colleagues at USAID for all your support in the conceptualization and planning of this event. And thank you to the IGWG team, Doris Bartel, Jade Lang, Devin Degnan, Grady Parmew, and the breakout room staff for all your support and helping to carry out this event. And of course, lastly, thank you to all the IGWG members for your attendance, your support, and your active participation in today's event. So I'll now pass it over to Diana Santillan, Senior Gender Advisor in USAID's Office of Population and Reproductive Health, for closing remarks.
Thank you so much, Francesca, and thank you for those of you who can stay on a little bit longer to hear. I just have a couple remarks to close out today, but definitely if you have to leave, as Francesca said, we greatly value your feedback, so we want to hear from you to continuously improve these events. So fill out the event evaluation survey, and the link, of course, is in the chat. So thank you so much for joining us today and participating in these important discussions. And thank you to the panelists who gave us a comprehensive overview of gender inequities in the health workforce that greatly affect women. As we heard, women on average make up 67% of the workforce, but up to 80, 90% in some contexts. And the panelists discussed so many important inequities that occur in working conditions, ranging from occupational segregation based on gender norms. That picture of the little boy and little girl really stands out in my mind there. They discussed the gender gaps in fair pay, in paid versus unpaid work, part-time versus full-time work, and multiple forms of violence experienced in the workplace. So we heard about efforts to also address these inequities. Lots of great examples of gender transformative supportive supervision, gender integrated pre-service education, gender transformative leadership training, and also efforts to strengthen gender-based violence response guidelines and monitoring systems. So those are just to name a few of the examples that came through. And we heard key actions that are needed from donors, which include earmarking resources for gender transformative work, deepening understanding and the evidence base for policy action, and mainstreaming gender equity and that lens through all of programs so that it's not just on the side. Also, we heard a lot about focusing on gender-sensitive recruitment and promotion practices, career development, and fostering just overall a more equitable, diverse, and inclusive workplace culture. And a key takeaway for me is that we really need more multi-sectoral approaches to take this work forward, and also an important connection between addressing these inequities in the health workforce and as a result, improving the quality of service delivery. These things are very much connected, and we need to keep that in mind. So the discussion points and the key takeaways from today's event, they will be incorporated into an IGWG product. And as mentioned, the recording and the slides from today's will also be posted on the IGWG website. So again, fill out the evaluation survey if you haven't already done so. But thank you again, and have a wonderful rest of your day. Until next time, bye.